are again sitting still in Annweiler, and I'm not alone. Again, I'm not alone. This time we do not have ice cream. This time we do have Lily Wildberry. And I'm not drinking alone, as it's not very nice to drink alone. I have a really special drinking partner, swallowing partner. So welcome, Professor Stefanie Daniels, to Iss Nix, the German Dysphagia podcast.
Happy to be here.
Yeah, happy to have you. And besides Stefanie is sitting Petra Puschinski, already known by most of our listeners because she have been on one podcast episode so far, and as
She's
we were,
famous.
she is, and as we were in Marburg at the first Dysphagia summer school last weekend, and you were talking about screening and in stroke patients, we thought it might be a good opportunity to have you with some nice cool drink sitting next to a really nice old water mill and talking about dysphagia screening in the stroke population.
Okay, happy to be here.
Say hello to everybody.
Hello. Everybody.
So why would you think screening is important in the management of dysphagia?
For stroke, I think it's important because stroke is such an acute event, and we're worried about identifying, I would say, aspiration risk acutely or quickly. More, identifying dysphagia is important too, but if a person's not aspirating, we may have a little more time to identify that dysphagia. But for aspiration, we want to identify someone who's at risk for aspiration or not at risk as soon as possible, because most patients who come to the hospital with suspected stroke are kept nothing by mouth until that screening. That's a regulation definitely in the U.S. and a lot of other countries, and so we want to get someone eating as fast as we can when we know that they're safe to swallow, that is no risk. And if they are at risk for aspiration, getting the speech pathologist consulted and to evaluate the patient as fast as possible.
So would you say, did you want to add something?
No, just to get another question.
Yeah.
If I'm allowed.
Of course, we are here to talk about swallowing.
So is it just about aspiration, or do you think it's still possible to detect dysphagia as such by screening?
Good question. When we looked at it, we could not do it for our screening. And we talk with screening, it's such a small point in time and such a quick evaluation. I don't know if a screening's enough to truly identify dysphagia. But you've got screening tools out there that say they do identify dysphagia.
Yeah.
And so even if they're identifying dysphagia or not, in this population, if it's a screening negative for, so the person passes the screen, be it for aspiration or dysphagia, I would still like the speech pathologist for that person to still have a speech pathology consult. And it may not have to be as quick because the person passed the screening and they're eating, but to really do a thorough evaluation to make sure there's no subtle dysphagia, because we're screening really with water. And to really do, a good dysphagia exam, you need more than just water. And I think since most of our screenings involve water, that's not going to tease out dysphagia. Granted,
Right,
the dysarthria might, the facial weakness might, but dysphagia is a lot more complex than that.
So, to make it clear, a screening is considered to identify people at risk for a certain not even disease, but symptom, which is aspiration in our case.
Right, but dysphagia is a symptom
Is a
too.
symptom. You're right. True.
But
you're right,
but
yeah.
I would say
Yeah, true. Yeah.
I would say for me a screening is to identify risk of aspiration because that's the really quick.
Yeah.
Can a person swallow safely or not? That's what we're wanting to answer immediately, and then with the more thorough eval, we do dysphagia. But again, there are some screening tools out there that say they screen dysphagia, and that's not to discount them. Does that make sense?
Yeah, because the screening is a pass or fail.
Fail.
Which is
Who's safe to eat, who's safe not to eat. It's really, you know, we think of it, who more can start oral intake and who cannot.
Okay, it's safe to eat or not to eat, but we are only testing
Yeah.
fluids. So I think the idea of a screening is to make sure that it's safe to swallow water without aspiration risk.
I think you can extend beyond water because that's again where the dysarthria may tell you something, or the facial weakness, depending on the screening tool you're using. But again, it's just who can start medication, who can start some oral intake at that moment in time, knowing that there's going to be a delay.
Yeah.
With speech pathology consultation, but who can we start giving medication to give some, you know, some pleasure for the person, some hydration, nutrition, and then still get speech pathology involved. So, yeah, that's how I interpret it. And I think there are various interpretations. You just need to be clear in your hospital which, you know, what is your hospital wanting to identify, and choose the screening tool that identifies that, be it aspiration, be it dysphagia.
So would you recommend to use a screening not just in the stroke population, but also in different types of... Because we do have a lot of acute stroke patients, and I do know that your criteria are very famous in Germany to use for... I mean, it depends on interpretation what it's used for. The Daniels, did you know actually that you are very famous in Germany? And I do know because the Daniels...
I'm shaking my head.
I know.
Wait,
I'm not finished yet. The Daniels test, and I have my hands like for Gänsefüßle.
Quotation marks.
Because I do know that this is not what it was supposed to be, and it was not your intention to be
a screen. A screen. It's part of the clinical swallowing exam, and some criteria that may help us be a bit more objective in recommending instrumental assessment. So for screening in other populations, so to me, the Daniels test, though I would not say...
I would say the Daniels criteria
Criteria
or the
things.
2 out of 6,
Right,
which is I use the term
it's
for
part
it.
of a clinical
yeah.
swallowing exam, which involves cranial nerve assessment, a longer assessment.
Yeah.
So, you know, really
and
involved...
it's just the criteria to...
But again, it's some criteria. I don't think it's just black and white like that.
But sorry to interrupt, but I think that is important to stress now, because the reception in our community is like, we do have a Daniels criterion or 2 out of 6, and they are recommended even by the guidelines of the neurology, neurology, dysphagia, doing isolated. And I think the talk you give us in Marburg makes me feel we do have to expand it, and we did a wrong interpretation, giving only the 2 out of 6, and that leads us to leave the other examination parts out.
It's a shot in time of a bigger exam, and I think it can really help guide. but I think you've got to look at the whole person. And definitely if I get 2 out of 6, I'm going to do that instrumental. But say if I don't, but I may see some other things happening that I'm suspecting pharyngeal dysphagia. I want to recommend compensatory strategies or something to help with swallowing efficiency or safety. I want to recommend rehabilitative approach because I believe there's an underlying impairment. I have to do an instrumental exam.
Yeah.
I believe that, if there's any time I'm wanting to recommend compensatory or rehabilitative, unless it's purely oral stage, I'm getting that instrumental exam.
Yeah.
Is that?
Yeah,
Like,
definitely.
Yeah. I don't think we can recommend compensatory, thickened liquids, posture, anything compensation, again, unless it's oral stage.
And even then, it's difficult from time to time.
I think
to
oral
see.
stage you can do a good clinical and get.
Yeah.
I don't think fluoro's definitely better than fees
Yeah.
for oral stage. You can
True.
see it, but sometimes I think a good oral exam will tell you what you need to know for oral stage. But it's rare that a person has just oral stage and not pharyngeal. So if I'm, going, I need rehab, compensation, or both. Instrumental, and I don't feel I can recommend either of those in good conscience without that. And for stroke, it's fluoro for me. That would be for the majority of patients, not all, but for the majority of patients, that's my exam of choice, video fluoroscopy. But you had asked about other patient populations. I think stroke lends itself because it's an acute event. We know there's a high risk of dysphagia and aspiration in this population, and it's acute. It's something that's happening quickly. But we think of other neurological diseases like Parkinson's disease, and that may not have dysphagia initially, or they might, and frequently they're unaware of their swallowing problem. So would it be good if we had a screening tool in place, a valid screening tool, that the neurologist, every visit, they could screen that individual with Parkinson's disease and say, whoops, I'm starting to suspect a swallowing problem or risk of aspiration.
Yeah.
Yes, because I don't know if a speech pathologist needs to do a clinical swallowing exam at each point in time. I think the speech pathologist should be part of that movement disorders clinic and really be involved. But I think for certain populations, yes, head and neck cancer, they generally can tell us if they have a swallowing problem or not. But if there's a screening tool out there, and there is, then definitely do, because these individuals for head and neck cancer, frequently during the radiation treatment, they'll have that short-term dysphagia, but then it's the year or two after. So it would be nice if the ENT doctor, the phoniatrician, had that screening tool in place to then administer every time to say yes. And so, again, even for head and neck cancer, they can frequently tell us they have a swallowing problem, but as the disease progresses, we get neuropathy, and that the sensation may not be there. Yeah, you've got it. You would like something more than just maybe an EAT-10 for that screen.
Look more for functional impairment and things like that.
Yeah.
What do you think about the ICU patients? Do we have a real valid screening tool available for those?
The only in a nutshell, I don't believe that's not a population I work with, and usually they're in ICU because of a disease. So if it's stroke, we would use the stroke.
Sure.
But let's say they're trach and vent
Or cardiac.
cardiac. No, we don't, unless maybe the 3-ounce water swallow test, because that one has been validated. They had 3,000 plus patients, but it would be important, I think, even for that screening, to look at go and look at the numbers that they screened, because they say it's valid for every population, but when their dementia numbers are an N of 10, meaning they only screened 10 patients with dementia, that's not valid.
Right.
It's too small of a sample size, and that. So I think if we're going to say, 3-ounce water swallow test for maybe dementia, for cardiac, we've got to really make sure it's inclusive. They've studied enough patients to say, yes, I feel confident. I've got the research to support it with this patient.
I really think, or I really like that you emphasize that it's not enough just to implement something that you heard or that you think would be enough, but really look into the paper and look into the methods of a paper, and not just read the abstract for the quality of a test, but also know about the strength and the weakness or the limitations of each procedure, because I really think most of the methods do have any kind of limitation,
Every
which
research,
is fair enough, but we really need to think of it and be aware of that, right?
There's no perfect research. We're dealing with humans, and what the question I get a lot with screening is, okay, there are these screening tools for stroke, but these are perfect stroke patients. They only had stroke. My patient doesn't just have a stroke, and I mean that's an important question and an important concern, but for research, that's how you have to start. You have to say the stroke is what's driving this problem. But then what would be nice, and we talked about doing with our screening tool, but we're just not getting around to it. So if anyone wants to do it, it's a study that I would be happy to give advice on how to conduct it, is so to take this rapid aspiration screen for suspected stroke and then validate it to all comers with suspected stroke, not just these perfect stroke clients. So if they had stroke plus Parkinson's disease, stroke plus cancer, stroke plus cervical spine disease, we're still doing it. And is this still valid or not? That's the next step. It could be with the Tour-Best, same thing. And saying now we want to see what it is, because in our study we had to disqualify or exclude almost 1,000 patients because of all these other things, and it's like,
but this is reality.
But again, you've got to start really clean, and once you get that information, then you expand it.
And if you work as a clinician, you have to be aware of what the tool is possible to serve.
True. And so you say stroke. Okay, my patient has stroke plus Parkinson's. Right now, this is the best we have, and I'm going to use that tool for stroke. But it's the Parkinson's that's the driving factor.
Yes. Yeah, this is what I was thinking, that you really need to get from this straight start, because otherwise you can't tell which comes from what. So I really agree that you need to start from that. You just mentioned your screening, the rapid aspiration screen for a suspected stroke. Yes.
RAS3 is the easiest.
So it's not the Daniel's test, and we will never use that term again. So could you? So could you tell us a bit of this new screen that you developed?
And so this is designed for nurses. It's a true screening tool. So to me, a screening is not done by speech pathologists. If I'm asked to see a patient, I'm doing a clinical swallowing exam. because a screen is designed to be quick, efficient, non-invasive. You're in, you're out. And so 5 minutes should be a screening. So it's made up of 3 items, if you will. If a person has a positive sign or fails an item, automatic consult to speech, they maintain NPO. So the items are age greater than 70, and there have been some concerns about that, and I'll talk about. So age greater than 70, dysarthria, and then a water swallow test. So if a person is 71 and older, whoops, they failed or had a positive screen,
Need a
you stop.
SRP come in.
And you stop right there. If they're younger than 70 or younger, you then get them to talk, listen for dysarthria. If it's present, stop. It's positive. If it's absent, go on to the water swallow test. We do start with 5 milliliters of water and listen for cough, wet voice, and throat clear. If any are present, we stop. If none are present, we do another 5 mils, same thing. If not, 90 mils water swallow test or 3 ounces, asking the person to keep drinking without stopping. And so our criteria for a fail on that is unable to drink without stopping. If a person is taking sips, I remind them again, keep drinking, don't stop. And if they stop, if they are still pulling the cup away, I then pull the cup further away and say, okay, we're done. But if, so that continuous drinking without stopping, then cough, wet voice, throat clear. I like the continuous drinking without stopping because I think what Leader and Suter were really suggesting is that will pick up the silent aspiration perhaps. And I think that's, you really want to challenge the person. You've got to push them and that. And I've seen that identify people. So with the age greater than 70, we've had pushback from our nurses because they said all of our patients, or the majority or a lot, are over 70. We don't like that. In our statistics, that helped. But we still had good statistics without it, not as strong, but good without it. So we told our nurses, sure, don't include that. Note it, but just, keep going. And if nothing else is present, start oral intake, but consult speech pathology. Definitely consult speech pathology for that so they don't get missed. Because, again, as we know, swallowing changes with age. Some people adapt and some don't.
Yeah, right.
Yeah.
So this is designed for nurses and acute care and should be administered, can I say administered, very shortly as soon as the patients come to the emergency?
We have a problem in the emergency department because it's so rapid down there and they have so much to do. It's frequently once they get admitted to the hospital, the stroke unit or the ward, or if it's to ICU, wherever they go, making sure nurses are trained. And then screening as soon as they can. Again, a person has to be awake and alert to be screened. If they're not, no screening. Swallowing's the least of their concerns. If they can't be seated, at least a minimum of 40 degrees, 45 degrees upright, preferably 90 degrees. No screening. If they have, if they're already on tube feeding and NPO, of course, no screening. In that, so
about awareness and consciousness of the patient, do you have they should be in a way for sitting upright and be conscious for about 5 minutes or 2, or?
Well, it's really is the person awake and alert. If a person's lethargic, because we did look at lethargy, so where you would be talking with the person, they're conversing. It may make sense, it may not, but it doesn't matter. They're just awake and responding. But the moment you stop stimulation, they fall asleep. That's really not awake and alert. So they have to be able to participate. If you find a person easily drifting off, No. If a person's just drowsy because they haven't slept enough, which is frequently the case, let them sleep and then come back a little later. Yeah.
That's really interesting. Yeah. So.
And I think with screening, and this is something that came up about a screening, should you administer, can a screening be something that includes things other than water? And I really think, again, we're asking our non-dysphagia experts to complete the screening. So typically a nurse, at least in the U.S., or a physician in training, they're not experts. And so I think asking them to administer thickened liquids, semi-solids, solids, it's not feasible. First of all, where are they going to get all of this material? And they're making other judgments, and if they're making judgments that then influence diet, no, screening is if you pass, it's a regular diet, regular diet, regular diet. If a person maybe needs, because of dentition, a chopped diet, okay, fine, you can talk with the client or family and that, but a lot of patients who are edentulous or without teeth can chew fine. Don't put your finger in their mouth. Be careful. So again, screening, it's got to be feasible too. So when choosing is, and I think if it goes beyond water, we're talking more of a clinical swallowing exam and that. So I would draw a line with kind of the definition of screening and say if it goes beyond that, it may be more of a clinical swallowing protocol, in that.
So, which means that we as a profession really need to be aware about what content is supposed to be in what context, and that it is definitely in our scope of practice to do thorough, full clinical swallow evaluation, that we need to advocate for instrumentals, for recommendations, for diagnostic and therapy recommendations. But at least in the stroke population, at the very beginning, it should be a really good screening that we can identify the patients at risk, but not to over-identify, so that the patients who are not at risk may be able to... Go for it.
That would be great if we had the screening tool that didn't over-identify, that was super high specificity, but we tend to sacrifice, and we have to, because aspiration can cause pneumonia, pneumonia can cause death. And so you're willing to take those few... it's got to be a few patients that you're over-identifying. Like with our screening, we don't have great specificity. And I think part of it, we may be a bit underpowered, meaning we need more subjects and we had 250 subjects that we did, and that's quite high, but I think given the incidence of aspiration, it was low, so I think we needed more there. But I think it's a trade-off, and you want to have otherwise you would be screening everybody, or keeping I shouldn't say not screening, but keeping everyone NPO until speech pathology, and we don't want that. But it's that balance. I think sensitivity has to be 90% or above. Specificity as high as you can get it.
Perfect.
Despite the fact that we don't have any standardized or validated clinical assessment tool, right? Or do we?
There's the Mann assessment of swallowing ability that is validated for stroke. So there would be the question, as a speech pathologist, we do have that. To be honest, as a clinician, I don't use, I want more items there. To me, it's not thorough enough. I don't think the cranial nerve assessment is as detailed as I would like. There are certain things that I would like, and I think, and again, with MASA, or the Man Assessment of Swallowing Ability, what was I about to say? Too much beverage here. How they define dysphagia and what they did, I would like some more information. I don't think it's as clear. Maybe their definitions. And then what they're saying that the MAN or MASA does is that, from what I'm getting, and again, you've got to realize that my interpretation may be different than yours,
Yes.
or
Right.
yours, Petra, or you listeners out there, and it's always go back to the literature and read that and see, am I just interpreting it wrong? But that it seemed to me that they were saying that from the MASA, you could recommend, possibly make diet recommendations, and you, again, from a good clinical swallowing exam, you can, but I don't believe you can say thicken liquids, that this chin tuck posture worked or not, and I do not believe you can make rehabilitative recommendations. And again, my interpretation from them is I think they think you can, and I would argue against that. Yeah, so because because they use that in their research, Giselle Carnaby and Mike Crary, and frequently that's their evaluation when they're doing treatment studies, and it's like, I'm not sure. How do you know the underlying impairment?
Right.
You cannot without looking at it. I really think we have to do another episode at some point and talking about clinical swallow examination and treatment. But I think for today and for the screening, we are done. And I really want to thank you very much, both of you.
Thank you.
It was a really nice meeting.
A good exchange of ideas.
Yes,
thoughts. That's fun.
And I'm pretty sure that we are going on talking for a bit now, because this is what happened earlier as well, that when we finished the episode and we were talking for like a couple of
And we
not
allow
hours,
us
but
some more beverages.
of course.
And we
do.
always need a behind-the-scenes podcast, right?
That's
Maybe
so good.
not. Maybe not.
So
Yeah.
I do hope that you have a great rest of your stay in Germany.
I'm enjoying it.
And you will be back next year.
In a year, yay!
In Heidelberg.
Yeah.
So whenever someone wants to meet you in person, they're all welcome to come to Heidelberg next June.
Please.
And for now, we are closing our episode. So we have a routine going on. So whenever we finish an episode, Alex is saying a sentence, and it's in English, so it's not that hard. So I'm going to say, stay hungry, and then you can say, stay tuned.
Okay.
Okay? So thank you very much, and in diesem Sinne, stay hungry.
Stay tuned.
Bye.
Tschüss.
Tschüss.